Hello, and welcome to the 27th Degree with Chris and Nancy from 27 Degrees Consulting. Our guest today is Dr. Yacoub, here to discuss diabetes management. But before we begin our conversation, I'd like to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. As always, you can support the 27 Degree with Chris and Nancy by signing up as a patron. Go to patron.podbean.com/the27th degree, or you can click on the link on our Facebook page. $5 a month gets you a shout out, bonus content, access to Basement Bites, which are my music videos, and a behind the scenes look at taping before and after the show. You can find the 27th Degree across social media, including Facebook, Instagram, and your favorite podcast platform. You can also subscribe to the 27 Degrees Consulting channel on YouTube. I'd like to give a big thanks to Ron Gamache for our intro music and EBM Studios for producing our show. So, Dr. Yacoub, thanks so much for joining us. We really appreciate you taking the time out to talk to us about diabetes, such an important issue across the world, and particularly in the Fall River, New Bedford area.
Well, thank you very much for having me. I'm very flattered that you guys invited me. Thank you.
So, Dr. Yacoub, can you tell us a little bit about yourself to start off?
Sure. So I'm board certified endocrinologist. I have started my endocrine career here in Fall River back in 1990. So I have been here for 22 years in Fall River. And I have the pleasure of working with Chris for almost the same duration of time. We've been good friends all of that time.
Yeah.
And it is actually a great place to work. Our patients are very, very kind. They always bring me cucumber and tomato from their backyard and wine during the Christmas holiday.
That's right. That's right.
And they are very, very appreciative, and I'm very appreciative to their mutual relationship that we have.
That's great. Can we start off by just you defining diabetes for us and what we'll be talking about?
Sure. So diabetes is one of the major chronic disease that is starting to become a major health problem because it is on the rise. So there is a very specific definition for diabetes, so people will know exactly and there will be no confusion. So fasting blood sugar, first thing in the morning before we eat, should be less than 100. Anything between 100 to 125 is considered as pre-diabetes, which is the stage before diabetes. Anything at 126 or higher is diabetes. If you happen to check your blood sugar 2 hours after meal, anything above 200 is diabetes. Anything under 140 is considered normal. Anything between 140 to 199 is considered pre-diabetes. There is a blood test that we do called the hemoglobin A1C, which measure your sugar average for 3 months. Normally, it should be less than 5.8. Anything above 6.5 or higher is considered diabetes. Anything between 5.8 and 6.4 is pre-diabetes. So there is normal, there is pre-diabetes, and there is diabetes. We are concerned about the diabetes and the pre-diabetes. The pre-diabetics have a 50% chance of a lifetime of developing diabetes, unfortunately, if they are not very careful with their lifestyle.
So if you're pre-diabetic, you can still kind of back away from the disease a little bit if you're careful and you do what you
that's
need to
actually
do.
the best part, because if you diagnose diabetes or pre-diabetes early on, you actually have a grace period of reversing that. And the best data come from a study called the Diabetes Prevention Program, or DPP. So DPP was done back in the late 1990s in the United States. It was duplicated in China and in Finland. And it showed the same exact results, whether you live in China or in Finland or the United States. So they have patients with prediabetes, and they divided them into 3 parts. The first part is they give them what's called intensive lifestyle change, meaning they are seen by a dietitian on monthly basis, and they are encouraged to exercise about 75 to 100 minutes per week. and they followed them over a course of time. The second group, they received medical therapy in the form of metformin. And the third group, they were giving a piece of paper about healthy lifestyle and exercise, and have a nice day.
So, I kind of know what the outcome of that study was.
So unfortunately, have a nice day group are the one who performed the worst. Most of them eventually developed diabetes. People who took metformin, they lowered the chances of diabetes by about 34%.
Okay.
People who followed the intensive lifestyle change, they lowered the risk of diabetes by 58%, almost 60%. And the study was duplicated in China and in Finland, and it was 60 and 62%. In the US, it was 58%. So the good news is,
that's great.
If you lose 7% of your weight, you are more likely going to prevent the progression of prediabetes to diabetes by about 60%.
So, one thing that's really, I think, is important for our viewers to understand is why diabetes is important to diagnose, right? What are the problems that a diabetic will run into? Could you talk a little bit about that?
Sure.
Because most diabetics, they may feel fine initially. They may not even know they have diabetes unless they have lab work done in the office and it shows a high blood sugar or an elevated hemoglobin A1C. And that's also, I think, an important point too. You need to get screened.
Extremely important. And I get asked this question 22 times a day because I see 22 patients a day. In addition to friends and family outside my regular work. So diabetes is a silent disease. So if your sugar is elevated, you are not going to have any symptoms whatsoever. Why is it important to know? Because diabetes is not a sugar disease. Diabetes is a heart disease. If you are diabetic, your risk for heart disease is 2 times higher than non-diabetic. And if you have other risk factors for heart disease, you multiply. So for example, if you're diabetic, your risk is 2 times higher. If you have high blood pressure, your risk is 4 times higher. If you have high cholesterol, your risk is 8 times higher. If you choose to smoke, smoking will increase your risk by 3-fold. So 16 times 3, so the risk is 48-fold higher. So it's really important to recognize if you're diabetic. And if you are, you're not only treating your diabetes, you need to treat your diabetes, your blood pressure, your cholesterol. If you smoke, you definitely need to quit. If you're not exercising, you need to change your lifestyle, which we're going to talk about later on in the program. So it is really important to get screened because you will have no symptoms if your blood sugar is high. Who should be screened? So there are national guidelines of people who should be screened. Anybody above the age of 40 should be screened once a year, which is another good reason for us to go and see our primary care doctor once a year and get an annual blood test, including fasting blood glucose, or as Chris mentioned, A1C. Those are usually very good.
And it's such a simple thing. I mean, you don't have to go and have a glucose tolerance test or any of that. It's just a simple fasting blood sugar, perhaps a hemoglobin A1C.
So if fasting blood glucose is perfect, if the patient happened to have something to eat that day, A1C is not affected by food because A1C measure your sugar average for 90 days. So one meal is not going to affect your number. So an A1C is a very good and valid screening.
The A1C, so it looks over 3 months.
Correct.
Is the test result more affected by the last month, or is it evenly distributed for?
So 80% of your A1C is accounted for the last 60 days. 100% is accounted for the past 90 days.
Okay. All right. Do you use the 40-year-old cutoff, or if you have a patient that's like 27 or 28 and they get their annual lab work, do you just throw that in?
I personally do it with all of my adult patients, regardless of age. So if they come in to see me, the standard for a healthy person is a lipid profile and a fasting blood sugar. And then if they have other diagnoses, I will add other labs dependent on what is going on. So, but I do it. I mean, I may be being more aggressive than many, but if they are 18 or older, which is what I see, particularly if they're overweight, they're getting a fasting blood sugar and they're getting a
Actually, the screening list goes beyond age 40. So women who are in the childbearing age, they should be screened once a year in the event they get pregnant. So you would like to know. Also people or women who give birth to oversized children, those are at increased risk of diabetes. So they should be screened on a regular basis.
What's the definition of an oversized child? Is that like over 8 pounds?
Correct.
Okay.
And if you have a strong family history, you should be screened annually, regardless to your background. And some ethnic groups who tend to be at increased risk of diabetes, usually African American and Hispanic, they can actually be screened at a younger age, as Chris mentioned, if they happen to be overweight or obese.
I mean, I just find that so many of my patients, my younger patients now, are obese. They have family history of diabetes. There's more reasons to screen than not to, quite honestly. And the smoking issue is so interesting. Not to be harsh, but if I have a diabetic who smokes, I tell them this is the kiss of death. You need to stop smoking immediately because of that increased risk of heart disease. It's so dramatic.
Correct. It's like adding gasoline to the fire. So if you have high blood pressure and high cholesterol, you multiply your risk of heart disease 2 times. But if you smoke, you multiply by 3. So high blood pressure, cholesterol, diabetes, part of it is genetic. You cannot really do much about it. But smoking is 100% your choice. So if you're aware you have diabetes, that is going to increase your risk of heart disease 2-fold, and you choose to smoke to multiply that by 3 times, that's probably not the best decision.
So my husband's sleeping, so I get to tell one of his secrets right now. But, he's a golfer. So he doesn't smoke. He'll deny it up and down, but he golfs quite frequently, and he smokes his little cigar. And if he does yard work, he smokes his little cigar. And now
he doesn't smoke cigarettes, but he smokes cigars. Right?
But he's not a smoker. But you have to take all that into consideration, especially if you're doing marijuana too. Like, people don't think that it's kind of all underneath that smoking umbrella, but it is. You have to take that into consideration.
So I like to think of it as poison. So if you take a little poison, it is harmful. If you take a lot of poison, it's much more harmful. But at the end of the day, it is poison.
Yes. Can we talk a little bit? You gave us some great information, some great stats that we'll be posting on our social media sites as well. Can you just talk a little bit about our area itself?
So Fall River is quite unique. So when I got my job, I didn't even know where Fall River is. I actually thought it's Western Massachusetts when I was still talking with the recruiter, and he told me it is Southeast Mass. So I came in for the job interview, and I love the place, and I have been here for the past 20 plus years. So I didn't realize that when I came in that Fall River happened to have the highest prevalence of diabetes in the state of Massachusetts. The highest prevalence of obesity, the state of Massachusetts. The highest prevalence of smoking in the state of Massachusetts. And sadly, the highest prevalence of cardiovascular disease or heart disease among diabetics in the state. When Chris and I started back in the early 1990s, there was something called the Diabetes Center of America, and there was a huge center here in Fall River. And Fall River was in the 7th or 8th in the country as far as heart disease among diabetics. Now we fell all the way down, not because we did a good job, but Texas is doing worse than us. So Texas, actually, the highest 10 areas of the highest prevalence of cardiovascular disease among diabetics are in Texas. So we came down, but still we are the highest in the state.
Something to be concerned about.
Yeah.
It's part of the reason I screen more aggressively than the guidelines
Right.
sometimes, because there's so much diabetes out there in this area. It's really remarkable. So
I remember when we started our cardiac bypass surgery program in the hospital here in Fall River, we were competing with another hospital in Cambridge for state support. And the state required that we need to do 50 cases in the first 6 months. Otherwise, they will pull the funding and send it somewhere else. We did 50 cases in the first 2 months.
Oh, wow.
So this is how prevalent heart disease among diabetics in the state, in Fall River.
let me ask you a related question, because this comes up all the time now. The whole aspirin issue. Now, I assume all diabetics probably have some element of vascular disease. So I put them all on a baby aspirin. And then this whole thing came out about primary prevention, of course, and everyone was stopping their aspirin, and patients who shouldn't have stopped it, who were on it for true disease, not for prevention of heart attack without heart disease. Are you putting all your diabetics on aspirin?
I do. I mean, the data is still supportive of aspirin. It's actually more compelling for secondary prevention, which is patients who already have cardiovascular disease. The problem is with the primary prevention, it takes a longer period of exposure and a larger number of patients. So that's why the data was kind of questionable. But some of the old data still support using aspirin as primary prevention.
Are we
Right.
talking baby aspirin or full
Yes,
strength?
small dose.
Yeah, I'll just get this out there because this question comes up at least every day with my patients. If you have heart disease, if you have vascular disease, if you've had a stroke, please don't stop your aspirin because you saw an ad somewhere that said aspirin is no good.
Oh my gosh.
Yeah, because I have that all the time. It happens at least 1 or 2 patients a week come in who have serious medical issues and stop their aspirin because they saw something in the news that made them think that aspirin was no longer recommended. But those studies were really about patients who did not have underlying vascular disease, heart disease. It was, as we call it, primary prevention. If you have those conditions, you need to be on aspirin if your doctor recommends it.
Correct. Which brings us back to the point that diabetes is not a sugar disease, it is a heart disease. So some people, they call diabetes is what's called cardiovascular risk equivalent. So people with diabetes should be treated as somebody who already have heart disease because the risk is very high. And unfortunately, here's some more stats that nobody will be very happy about. 85% of diabetics are overweight or obese. 75% of diabetics, they have high blood pressure. 70% of diabetics, they have some kind of abnormal cholesterol. And 50, or to be exact, 49% of diabetics, they have some kind of chronic kidney disease. Each one of those is an independent risk factor for heart disease on top of the diabetes. So that's why when we see somebody with diabetes, our main concern is, in addition to controlling the sugar, but also lowering their future risk of heart disease by treating all of the possible modifiable risk factors. Modifiable means the things that you can modify, which is pretty much everything other than your age, because you cannot change your age. I wish we can, but we can't.
Chris tries.
So for the diabetes, the high blood pressure, the cholesterol, the smoking, chronic kidney disease, all of those things combined can actually increase the risk of heart disease. And that's why I totally agree with Dr. Junkas that aspirin is one of the very simple, very easy, very inexpensive things that you can do, in addition to the other measures that we will cover later on.
So just for our audience, just to back up a little bit, the problems that you can develop with diabetes, because it really is I guess it's a whole body disease, really. I mean, we've talked about heart disease, but we have stroke, heart disease, peripheral vascular disease, kidney disease, neuropathy. Did I leave anything out?
Yeah, there are a couple of more as emerging. So you're absolutely right. So I actually like to simplify it of breaking into 2 groups. One group related to the sugar, one group related to the weight and the other risk factors. So the things that are purely related to the sugar that everybody unfortunately get, even if they do not have the other risk factors, what's called a small vessel disease, or the damage that happened in the small blood vessels, which are the blood vessels of the eyes, what's called retinopathy.
We got retinopathy.
Blood vessels of the kidney, what's called retinopathy, and the blood vessels of the lower extremities, which is called neuropathy, or loss of sensation and the tingling and numbness and the burning sensation and sometimes the pain that patients can get, what's called neuropathy. And then you have the disease of the medium-sized vessels. Those are the blood vessels of the heart, increase the risk of heart disease. Blood vessels of the brain increase the risk of stroke and mini stroke. Blood vessels of the lower extremities increase the risk of amputation and ulcers and non-healing ulcers. And now there is a new thing that is considered related to diabetes complication, which is those people with diabetes and overweight or obesity, they have what's called a non-alcoholic fatty liver disease.
See a lot of
Or
that.
fatty liver. Fatty liver affecting about 70 to 80 million people in the United States, while diabetes is affecting 35 million people in the United States.
Yeah.
Fatty liver disease is now the #1 cause of liver failure and the need for transplant. It's no longer viral hepatitis because now it can easily be treated. Now with the epidemic of obesity and diabetes, this combination can actually cause some serious damage to the liver.
I'm amazed at how many people have fatty liver in this area. I mean, it's so common. And then many of those patients have cirrhosis, or as we say, fibrosis, which is another term, of course. But it's remarkable, isn't it?
It's funny you said that, because when we started our weight loss clinic at Primacare back in 2017, I thought, since I'm a diabetes specialist, so I am going to get tons of diabetics. And I was very excited because diabetics are very, very sensitive to weight loss. It doesn't really take much. All it takes is 3 to 5% weight loss. And you see huge improvement of your blood sugar and marked decrease of the need for insulin. I actually was surprised that the number one comorbidity or the most common disease associated with the extra weight, at least in the Fall River area, was not diabetes. It was actually fatty liver disease. To the point that we invested in a technology called FibroScan, which is a very simple and easy way to measure the degree of fat in the liver. And it turned to be extremely prevalent.
It's incredible. It really is remarkable.
Can we just back up a little bit too, and like, how does diabetes, what's the disease like in your body? Like, what's not working right? And so we talk about pancreas. Like, I hate to use the term broken, but what's broken in your body that you have diabetes?
So the two major problems that we have in the diabetes is the fat cells and the what's called the beta cells of the pancreas, or the cells that are producing insulin. And the problem does not start in the pancreas, believe it or not. The problem starts in the fat cells. Now we're talking about type 2, not type 1, because type 1 is a
whole different disease.
So let's just focus on type 2. So unfortunately, as a society in general, we are all getting overweight and obese.
Right.
So 85% of people with type 2 diabetes are either overweight or obese, meaning they have what's called a body mass index above 25. If your body mass index, which is the relationship of your weight to your height, is above 25, you're considered overweight. Between 25 and 30 is overweight. 30 or higher is obese. And obesity, we break it down to class 1, 2, and 3. So class 1 is between 30 and 35, class 2 between 35 and 40, and class 3 is above 40. So as the prevalence of obesity is happening, the fat cells' function is to store fat. So fat cells can work in one of two ways. They can keep storing fat until they reach their maximum capacity and they become dysfunctional. And what happens as we are eating more and accumulating more fat, that fat is going to seep out of the fat cells into the rest of the body where it does not belong. If it happened to be stored in the liver, this is fatty liver disease. If it happened to be stored in the pancreas, it will affect the beta cell that is producing insulin, and the beta cell becomes dysfunctional, and this is when you develop diabetes. If it happened inside our organ, what's called the omental fat, you get inflammation and atherosclerosis. If it happened in the heart, it's heart attack and stroke. If it happened in the brain, it's stroke. If it happened in the kidney, it's kidney disease. So the problem starts in the fat cell. Some people, what they call them healthy overweight or healthy obese, their fat cells are able to multiply. And when they multiply, they can actually store more fat without becoming dysfunctional.
Oh, good.
Yeah. So, you will have more fat cells, but you are still healthy. But when the fat cells reach its capacity, cannot multiply, and can no longer store the extra fat, you have the fat where it doesn't belong. We call it, like the medical expression is ectopic fat deposition, or abnormal fat accumulation where the fat does not belong.
Okay.
So fat normally belong in the fat cells under the skin, doesn't belong in the liver, doesn't belong in the heart, doesn't belong in the pancreas. So that is the first stage of the beginning of diabetes. And this is when you can actually catch patients while they are still pre-diabetics. And you can actually reverse that by improving their lifestyle and help them lose the weight. All of those things can be reversible.
So when you say improving, well, let me ask one question before we get into the lifestyle changes. So I'm 26, 27. I'm not seeing my doctor every year. I don't feel like I need to, maybe it's 5 years. Like, am I going to know I'm a diabetic? Like, what are my signs going to be if I am a full-blown diabetic and I haven't been screened? Like, what am I going to be feeling?
The answer is no and none. So you are not going to know. So because if your blood sugar is moderately elevated, you will not feel it. The symptoms are usually increased thirst and frequent urination, and it doesn't happen overnight. It's very slow. So you can actually be surprised. You have people with a blood sugar above 250 all the time. And you ask them, do you go to the bathroom more than usual to urinate? I said, oh, that's the norm for me. I usually wake up 2 or 3 times. So they kind of get used to it. And unless you really see a doctor on a regular basis, you will not be able to tell. Unfortunately, in the United States, your typical type 2 diabetic have diabetes for 3 years before the diagnosis is established. And the diagnosis is usually established by accident. That you happen to get sick, you go to the emergency room because you cut yourself. The doctor at the emergency room, they do a metabolic panel or blood test, and by accident your blood sugar is high, and the doctor will tell you, we already sutured your leg, but we found that your sugar is high. Please call your primary care doctor and follow up with him or with her. And sometimes, which is really sad, because I still practice medicine in the hospital, I go to the hospital every third week. Sometimes the first presentation of diabetes is a heart attack. So you have somebody coming with a chest pain, you do the heart hormone enzymes, something called troponin, it's very high, and you find that the blood sugar is high. So they have been diabetic all along, and they didn't know until the first manifestation of diabetes is a heart attack.
Well, you're talking about the kind of the small vessel or microvascular disease. That takes about 5 years or so to develop, if I remember correctly.
Correct.
If you've had diabetes for 3 years without it, doesn't give you a lot more time before you've developed some of those complications.
Correct.
So that is very frightening.
And
that's why it's important to screen.
Sometimes we get referral from the eye doctors, and they will send the patient and said, your patient is diabetic. How did the eye doctor find out? Because they did a routine physical exam, and they already have established complications in the eyes that are very, very characteristic to diabetes. And it is really sad when the eye doctor make the diagnosis, because it means that your disease is already so advanced and it has caused complications. So as Chris mentioned, usually the microvascular complication, it takes 5 to 7 years from the time of the onset of diabetes for those people who are not well controlled. Those who are well controlled never get these complications.
That's the beauty of it. It can be controlled.
Exactly, because once you diagnose the diabetes and you act on it and you change your lifestyle, this is actually when things start to become stabilized, and you basically prevent any further complication down the road. The problem is those people who never see their doctor, they don't keep their follow-up, they do not go for an annual physical and get their blood test. And as Chris mentioned, it's really very simple. It's a simple blood test, whether you do it fasting or non-fasting, and you have a good physical exam once a year, and this is all it takes.
And there's a whole other class of patients who go to for their physical every year, and you order labs every year, and they never go, and then you realize you haven't been for your lab work in 3 years. You need to go. So if your doctor orders lab work, please get it. It's important. There's a reason for it. So.
And with that, I think we're probably at a good time where we can do a commercial break.
I think so. Let's do that.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
Welcome back, everyone. So this is a great conversation. It really is.
I'm enjoying that.
Yeah, this is wonderful. We're having a lot of fun. Let's talk a little bit about, we talked a lot about diabetes and complications and what the disease is really about. Can we talk about how it can be prevented, or if once you have it, how you can control it, or if you're pre-diabetic, how you can prevent it from progressing to diabetes? What are some simple things without medications? Because that's a whole other conversation that we could talk hours on.
Absolutely.
So
this is actually what Nancy pointed out early when I mentioned the word pre-diabetes, and her eyes was kind of wide open, because this is actually the best timing. And back to your point, that's actually the beauty of having a blood test on a regular basis and trying to catch any kind of disease, whether diabetes or anything else early on. So the best data come from the diabetes prevention study, and it showed 7% weight loss translate to 60% reduction of the progression of pre-diabetes to diabetes. So study showed if you are diabetic already, if you lose as little as 3 to 5%, you tend to have significant improvement of your blood sugar. If you lose 5% to 10%, you actually tend to improve things. And more than 10%, you tend to have fantastic results.
So it's just weight loss, isolated weight loss. Like, it doesn't matter how you lose the weight?
No, it's obviously you need to lose the weight the healthy way, because there's some people, they lose the weight in a very unhealthy way.
Well, suppose I love exercising.
Correct.
And I'm still eating my Twinkies, but like my exercise regime is great.
So exercise by itself is not enough. Diet by itself is not enough. Behavior change is not enough. So I like to call it the tripod. So just imagine that you do have a chair with 3 legs. You break one leg, that chair will never be able to stand straight.
Yeah.
So there's the 4th leg, which is the medication, but we're going to see that for the diabetes. Now we're talking about pre-diabetes or even early diabetes. They don't need to be a medicine. So the 3-legged approach is I hate the word diet because diet is something you do for a few weeks, a few months, and then you quit and you go back to your old habit. So I like to call it meal plan. Okay, so let's stick with that for a second.
I like that.
Number 2, activity, not exercise, because some people get very intimidated by exercise, and you do not really have to go to the gym in order to get the benefit of the exercise. So I would call it activity. Number 3, behavior change, and that is the most important one. Why? Because that is the only reason you'll be able to stick to a meal plan or an activity plan for a long time. How long does it take for people to change habit? 3 to 6 months. How long
Really?
Yes. How long does it take for people to establish a new habit? 6 months to a year. So behavior change is extremely important because it requires a lot of repetition until it becomes part of your routine. So I always ask my patient, do you ever put brushing your teeth on your to-do list? The answer is no. It goes without saying. For those people who brush their teeth, some people do not. But if you happen to be in the habit of brushing your teeth on daily basis, it is engraved in your daily routine and you do it without thinking. So in order to have this routine in your lifestyle, as far as meal plan and exercise, you need to practice that on a regular basis. So repetition, positive reinforcement is very important.
Practice makes perfect.
Exactly.
So are you promoting or supporting a particular type of diet for the weight loss?
Okay.
Like,
We'll get to that. So let's just go back to point number 3 and then we'll get to
Okay.
1 and 2. So
Okay.
point 3 is the behavior change. It boils down to 2 simple concepts: preparation and tracking. So
Okay.
preparation means buy the food, prepare your food, so you do not feel the urge to go to your favorite fast food place because you did not pack your lunch with you at work, or because you happen to be passing by the Golden Arch and you decided to go and get French fries. So preparation is really important. And I encourage all of my patients to do their food shopping on a weekly basis because we strongly encourage a lot of fresh fruits and vegetables. So you would like to have the food
Yes.
fresh. So you buy the food, prepare it, and we encourage them, if they are spending extended hours at work, to pack their mid-morning snack, their lunch, their mid-afternoon snack, and if they happen to have very long hours, like Dr. Junkus, who stays in the office until 7 o'clock, to get an extra snack, so you will not end up eating the wrong food.
Right.
The tracking, you have one of option. You can actually write things down, or you can have a digital kind of a diary. And they actually did an interesting study on people who lost 30 pounds and they kept it for 2 years or longer.
Okay.
And they sent them one survey after the other, and they collected the information in a data bank. And they found that those people have 5 things in common. And one of them is they keep track of their food intake. So preparation and keeping track of your food intake, that's basically as simple as it gets. It is easier said than done, but it actually requires a lot of motivation. That's why it has to be repetitious and it has to be done on a regular basis. And eventually
Right.
that will be part of your daily routine. So that's your lifestyle changes. Okay?
So sometimes that's really a great little nugget of information, because once you start tracking what you're eating, you're like, oh my God,
Correct.
I'm not.
And actually,
7 o'clock, look
our
at
patients
this.
love it because when they go back and look at it, they look at the weeks when they lost
Yes.
2 to 3 pounds,
Yes.
and they looked at the weeks when they gained 2 to 3 pounds.
Right.
And it is written in their own handwriting. So the week that I did well, I ate X, Y, and Z. The days when I did bad, I ate A, B, and C.
Right.
So you will be able to know. Back to your other point, as far as meal plan, everything in moderation. So there are tons of different kind of meal plan. The good news is which one is the best, the one that you can stick to. So they did a study on the
So true.
ketogenic diet, a
Yes.
study on the Mediterranean diet,
Yes.
a study on the low-fat diet, and they found at the end of the day, they all performed the same.
Oh,
So the weight loss was the same. Some of them
Okay.
did better than others as far as durability, as far as long-term. So I usually tell the patients, whatever that you think you are going to stick to is probably the best one.
that makes so much sense.
Not necessarily the Twinkie diet, so it still have to be kind of healthy. So the healthiest one, and the one that I recommend to all of my patients, is the Mediterranean diet. So Mediterranean diet was based on the Lyon Heart Study. And the Mediterranean diet is lots of fresh fruits and vegetables, a lot of olive oil, and very, very little processed food. And they showed not only those people, they lowered the risk of diabetes, not only they lost weight, but they also showed significant reduction of the risk for heart attack.
That's great. That's great to know.
So for diabetics, well, I mean, a meal plan is good for everybody, but for diabetics, you probably might need to zoom on the carb intake, the carbohydrate, which is the starch. Starch comes from bread, from pasta, from potato, from sweets, from fruits. So there has to be some kind of a limit to it. So for your average man, we recommend 45 to 60 grams of carbohydrate for breakfast, lunch, and dinner, and 15 grams for their bedtime snack. For women, we recommend 30, as in 30, to 45 grams with each meal, and 15 for their bedtime snack. What is 15 grams of carb? We call that a portion. So each portion of carb is 15 grams. So for women, it's 2 to 3 portion with meal, 1 portion for snack. For men, it's 3 to 4. How can you figure that out? It's not really that complicated. There are tons of apps. My favorite is called Calorie King. You can actually download in your phone for free. And you can put whatever food and it will give you the grams of carbs. And after a while, if you think about it, we are creatures of habit.
Yes.
I eat the same 4 or 5 items for lunch. I eat the same 5 or 6 items for dinner. I eat 20 different items for my bedtime snack. I tend to mix it a little bit. But generally speaking, I mean, the food that you like to eat on a regular basis, you can actually store it in your app and you can import it and just try to stay within your budget.
One of the guests that we had on said, like I was asking him about what's the best foods to eat. And he's like, if you think of a supermarket store, it's all on the outer perimeter. When you get to the inner aisles, it's like more of your processed stuff. So
most of the fruits and vegetables is as soon as you walk in.
Yeah.
And as you get a little bit deeper, it gets unhealthy.
Yeah.
Right.
Yeah. So stay away from the center.
So stay the first and second row and then, you're done.
Good point. Yeah, that's a great
So
point.
the third-legged approach is exercise. So we talked about the meal plan. We talked about behavior change, which is preparation and tracking, and then exercise. Exercise, you will need to do 2 things, cardio and resistance. One is not enough, and one is definitely, you don't want to dominate one versus the other. When you do cardiovascular, which is anything that will raise your heart rate, you are protecting yourself from losing muscle.
Okay.
When you do resistance training, not only you're protecting your muscle mass, you are increasing the muscle mass. Why muscle mass is very valuable like gold? Because muscle mass dictates your metabolism.
And resistance training is like lifting weights.
Weight or stretch bands, which is my favorite thing. We'll get to that in a second. So you would like to protect your muscle, and if possible, try to increase your muscle mass. It will improve your posture, improve your strength, improve your stamina, and raise your metabolism and protect you from regaining the weight after you lose it in the first place. So cardiovascular, all you need is a comfortable pair of sneakers. Just go for a nice walk.
Yeah.
You start with as little as 10 minutes, depending on your physical condition, and try to increase. The recommendation for diabetics is anywhere between 100 to 150 minutes per week, which is 20 to 30 minutes 5 days a week. Most of our patients, they do exceptionally well in the spring and summer. Most of our patients do not do as well in the winter. Right. So I usually tell them, try to find something you can do indoor and something you can do outdoor. So have your sneakers, go for a walk outdoors during the nice weather, and have like a treadmill or a bike or an elliptical, or even just if you can find an indoor place that is nice and heated during the winter, you can go to.
Right.
Resistance training, free weight obviously is the ultimate, but it's not really very easy and not very practical. The most practical thing is the stretch bands. I actually like it a lot because you can get a bundle of 3, low resistance, medium resistance, and high resistance. And for the ladies who are listening to us, they come in pink.
Oh, well, there we go.
So I actually like to start with the low resistance, 10 minutes. So 10 minutes, 3 times a week. And you try to mix it up a little bit. So one time you do upper body, arms and shoulder. One time you do lower body, thighs and leg. And one time you do core, which is the lower stomach and the lower back.
You know what I like about that? You can do it lying in bed. You just have money and like.
I actually tell all of my patients, keep it on your coffee table near your favorite chair. So while you're watching TV with your family, you will have the stretch bands.
Yeah.
So you start with 10 minutes and you try to increase and you try to maintain it at half an hour, 3 times a week.
Yeah.
It's a great exercise, very inexpensive. $20 is the cost you pay for it once. And as long as you use it on a regular basis, you get a very good return on your investment.
I think there's this misunderstanding that you have to go to a gym and you have to exercise aggressively for an hour. And then what I find is when patients do that, they jump right into it. They quit doing it after about 3 weeks. or 4 weeks. Maybe they go 2 months, but this is more realistic.
Correct. I mean, if you can go to the gym and do high intensity interval training, that is wonderful, but
It's
it
great.
is not meant for everybody.
No.
So one of my patients happened to be a personal trainer who works in the gym. And she usually told me that the busiest day of the year is January 1st.
Yeah.
Sure.
So most of the regular gym goers, they usually skip the first week of January. So most of the people with the New Year resolution, they usually start on January 1st, and by January 7th, kind of dies down.
Right.
And then your regular customers come back on
But
January.
by mid-January, it's just the regular customers. And certainly there's nothing wrong with going to a gym regularly and doing all that. But I think for someone who hasn't exercised and they're starting out, what you're saying makes probably better sense.
And, it's doable. It doesn't require a lot of equipment. It's definitely very inexpensive between having a comfortable footwear and, the stretch bands. But the key is consistency. And that's why we go back that it takes 3 to 6 months to change habits, 6 months to a year to establish a new habits. That's why a week or two of exercise is not really going to give you a lot of benefits. So it's always good to start low and work your up slowly. But the key is persistence and consistency.
What about alcohol? We've talked a lot about food. What about my beer and wine?
So like everything in life, everything in moderation is reasonable. So you do not want to excessively drink because eventually the calories from the alcohol is going to add up to your carbohydrate intake, and eventually it's going to affect you in a negative way.
Yeah.
However, if you have small amount of alcohol periodically, it's not harmful. So what they consider a small amount is 2 ounces of alcohol for women a couple of times a week, 4 ounces of alcohol for men a couple of times a week. 4 ounces, not 4 6-packs.
That's not a lot, really.
Yeah, so it's just like, a glass of wine once or twice. I mean, some people say every day is good for your heart, but again, let's just be realistic. From a diabetes standpoint, you do not want to have alcohol every single day.
All right. Perfect. So you tell me I have diabetes when I'm in your office or something, and I haven't seen you in a couple of years, so we're like full blown now. Like I'm past that pre-diabetes stage. Hello, here I am. Am I crying? Am I like, what am I doing? Am I like, I'm seeing you, and like when we've talked about the diet and the exercise and all that, but can we start moving into the medication piece
Correct.
of it? Like, am I on insulin right away?
No,
What's
you don't
happening?
need to start on insulin. So the good news is now you recognize that you have diabetes. You're not really very happy about it. And you have horror stories from your grandma who had diabetes and had a lot of complications.
Yes.
So the good news is in the year 2022, we have 12 different classes of diabetic medication. And within
No
each
way.
class, there are probably like 3 to 5 different options.
Really?
So when I started with Chris back in 1990, we only have 3 classes of medication. Insulin, something called sulfonylurea, and metformin was just
Just
basically
coming out.
approved in
That's it.
1995.
Yeah.
So from 1995 until now, we have 12 different classes, not 3.
Oh my gosh.
So we have a lot of options. So
It's actually overwhelming how many options
it
we
is.
have.
It is. And
It really
it is
is.
quite complicated, and it's really very hard to keep track of. But it's a good problem to have
Sure.
because it's always good to have different options. And now the variety of the mixing and matching of the different
Yes.
medication is incredible. So let's just start. Who need to be on medication and what is a good standard for the blood sugar? So usually the conversation I have with my patients, well, you're newly diagnosed diabetic. It's not the end of the world. Yes, diabetes is a serious disease, can increase your risk for heart disease and other complications. But if you do a good job between changing your lifestyle and taking the right medicine and maintaining your blood sugar in a good range, you should have a normal, healthy life, and your risk of complication is very good.
I find myself always bargaining with my doctors. Like, I'll be good for the next 3 weeks. Let's just hold off and let's see how I do. And then inevitably, I don't.
Correct. And that's why it is now we're talking about the 4-legged approach, it's not 3.
Okay.
So we're talking about the meal plan, we're talking about exercise, we're talking about behavior change, which again boils down the most important one, because this is the one that will keep you going and keep you motivated for a long time.
Yeah.
So it comes again to preparation and tracking. So some people actually do not put a lot of emphasis on leg number 3, but that's actually the most important. And there's
Yeah.
a lot of psychology that goes in it.
There
Right.
is.
So, as physician, and I'm sure that Chris will agree with me, we are physician, we are psychologists, we are cheerleaders,
Yeah,
We
that's-
are friends, and sometimes we have to add a little bit dose of tough love.
That's
Yes.
you know that's perfect because I'm nervous, like, and I'm in the medical field, and I know like I'm gonna get a talking to sometimes, and do I, the impulse to say, hey, I have to reschedule my appointment because I just like, so you're absolutely right. Like you have to find that right balance that's gonna work for that person, so they don't feel like they're beat up,
Correct.
but they know
Yeah.
that they have a responsibility to their health.
True. And it comes to the numbers. So your blood sugar before you eat ideally should be under 110 up to 130 is acceptable. 2 hours after you eat, your sugar should be 140 or less up to 180 is acceptable. Your hemoglobin A1C should be less than 6.5% up to 7% is acceptable. So anything above those cut off is unacceptable, and that means something else needs to be done. So every single time we emphasize the importance of estimating the carb intake and stay within your budget.
Right.
Every single time we touch base on cardiovascular training, how many minutes are you walking, or what you do on your cardiovascular and your resistance training. Every single time the patient comes in, we review the blood sugar reading. Back in the days, we used to ask the patient to prick their fingers
Yes.
once or twice and sometimes 4 times a day.
Right.
The good news is now we have this new technology called CGM. CGM stands for continuous glucose monitoring. And there are a couple of devices that are commercially available that the patient will wear. And that device will measure your sugar every 5 minutes. You don't have to do anything other than
Nice.
just scanning. And once every 2 weeks or once a month, we will be able to download the readings.
Isn't that great?
So
Yeah,
back in the
it's-
days, we used to ask our patient
It's
to
been
physically come
Mhm.
and bring the machine, and sometimes they do not have the transportation. Now, if they happen to use the smartphone, all we have to do is to go to the cloud. Patient doesn't have to do anything, download the reading, and once a month we'll call them and tell them your numbers are high or low. This is what you need to do.
And I've had a number of patients that I could never really get well controlled before this technology was available. They were hesitant to check their finger sticks or whatnot. You know the story.
Yeah, of course.
And now it's some of those have really come under much better control.
And it is so self-motivating because
Mm.
every time you eat, now you have the luxury of looking at your scanner and look at your blood sugar reading. And if you know your blood sugar shot above 250, clearly you know whatever you ate
Right.
did not agree with you.
Gives you a lot of feedback.
So the
great
next
feedback.
time around, when you have the same meal, you're either going to cut the portion or just avoid it completely and substitute it with something else. And you're absolutely right. I have patients who have an A1C above 10% forever. And once they started to use the CGM, their A1C, without me doing anything, just being on the same treatment, but just looking at the blood sugar reading and knowing what
Right.
spikes their blood sugar and what does not, their A1C is down like 7.5, 8, and we're getting there close to the
Right.
ultimate goal of 7%.
Well, there's certain foods that will really screw up your numbers, like we've heard Chinese. It's like, don't go out and eat Chinese food because it will just like wreak havoc with your numbers.
Yeah, so now we're getting into the nitty-gritty details. So
Okay.
when it comes to carbs, there are 2 things that you have to keep in mind: the quality and the quantity.
Okay.
So we agreed the quantity of the carbs should not exceed 45 grams on any given meals for women, 30 to 45, and for men, 45 to 60. Within the carbs, there are good carbs and there are bad carbs. So we have an index called the Carb Index. And the Carb Index is from 1 to 100.
Okay.
Anything above 50 or higher is considered as a high glycemic index. Anything
Okay.
less than 50 is considered low glycemic index.
Okay.
Low glycemic index is any carbs mixed with fiber, which is fruits and vegetables. Anything above 50 or higher is processed food that does not have any fibers. The pasta, your rice, your starchy vegetables like the corn, the potato. Those are the things that spike your blood sugar. So within that budget of 45 grams of carb, you can actually have some carbs that will spike your sugar more than the others. And that depends on the composition of the food. So the more processed the food, the worse it is. The more raw the food, the better it is. And that's why fruits and vegetables is your best friend when you are diabetic, because they tend to have a lot of fiber content that does not spike your sugar as much.
Dr. Yacoub, if your blood sugar dips and like you feel it, like what's the best kind of food to eat to get rid of that feeling?
You mean having
Like
a low
peanut
blood
butter and
sugar
crackers.
reaction?
Yeah, yeah.
So peanut butter is probably not going to work very fast because the fat in the peanut butter will delay the absorption of the carbs. So that's actually not your best choice.
Okay.
So you would like to have something that will bring your sugar up very quickly.
Okay.
So we use what's called the rule of 15.
Okay.
The rule of 15 is 15 grams of carbs, wait 15 minutes and check the blood sugar. If you're still in 2-digit, take another 15 grams of carbs until your sugar is 3-digit, which is 100 or higher. The reason is sometimes when your sugar is low and you overreact,
Yes.
and you eat and drink everything in sight, 2 hours later your sugar is 250 or 300.
Okay.
So the best thing is glucose tablets. So we usually tell our diabetics who are taking medication that can potentially cause low blood sugar reaction, only 3 of them. Insulin, any kind of insulin, medication called sulfonylurea like glipizide and glimepiride and glyburide, and short-acting medication called neglitinide. Those are only 2 available on the US market,
Okay.
one called Starlix and one called Pranglin. So those are the only 3 classes of medication that can cause low blood sugar reaction. The good news is the 9 other classes of medication have a risk of 0 hypoglycemia.
Oh, wow.
So when we get to the medication later on, we try to choose medication not associated with low blood sugar reaction. But if you need to be on insulin, you need to be on insulin. So 4 of those glucose tablets are 15 grams of carb. So you chew it one at a time. When you chew it, it is absorbed from the blood vessels under your tongue, and it goes into the circulation, and it works very quickly. So 4 glucose tablets. Wait for 15 minutes, recheck your sugar by either finger stick or through your sensor. And if you're still under 100, repeat the process every 15 minutes until you're above 100, and then you're safe.
Because the hypoglycemia, of course, in older persons can be a real issue.
It is. It's
in
a
anyone, but
major
particularly-
problem, especially in older
You
people.
know, and I do a lot of nursing home work and a lot of geriatric care. So with those folks, particularly if they're in the nursing home and they're debilitated, I don't try to get their hemoglobin A1C to 7. I'm fine if it's at 8. I don't give them sulfonylureas because they fall and they break their hips, and that's just devastating.
What's an
So
example of a sulfonylurea?
like glyburide,
Glipizide and glimepiride.
glipizide.
There are only 3 of them.
yeah, they're older meds, but you know, as Dr. Yacoub mentioned years ago, those were the mainstay of treatment.
Right.
It was insulin, that, and metformin, and then after that, these newer drugs came out. And so I don't use sulfonylureas hardly ever anymore.
So the good news is in older people now we have a lot of other options, but sometimes you still need to be on insulin. So the long-acting insulin tend to have a much lower risk of having a low blood sugar reaction compared to the short-acting insulin. So we're still using long-acting insulin in older people to try to get their fasting sugar under control. Fasting sugar is half of your battle. If you get your morning reading under control, it will be much easier to control your blood sugar throughout the rest of the day. If your fasting sugar is very high, most likely the blood sugar will be very high for the rest of the day. So as I mentioned earlier, our goal is to get the blood sugar under 110. In older people, between 110 to 130 is safe. And then you can use some of the newer medication to control the blood sugar for the rest of the day that are not associated with risk of hypoglycemia. And you do not have to get to an A1C of 7 in older people because the risk of falling is very high. If they fall, they can break their hip or get bleeding in their brain. Both are equally devastating. So up to 8% is acceptable. And I think we can easily get a lot of our older patients in nursing home or those who live independently at home and maintain their level of independency without the need to go to a nursing home by having a combination of medication that can get the job done.
So when someone's a new diabetic, like what's the, and I know everyone's an individual, but what's the most common starting point with drug therapy?
Okay, so it depends on how high your blood sugar. Obviously, insulin remains the most powerful medication that can bring your blood sugar within hours. Most of the other medication that are non-insulin based, whether they are pills or whether they are injection, they take anywhere between days to weeks to work. So it depends on the sense of urgency. For example, we see somebody in the hospital with a blood sugar of 400 or 500. That person is actually going to walk out of the hospital with 4 injections of insulin per day. However, if they do a good job and keep the blood sugar under control, this is when you will be able to convert some of the short-acting insulin injection to the other. Since we only have very little time left, I just want to focus on 2 newer medications. 2 classes, one called GLP-1, and there are 3 or 4 members in that class. and another one called SGLT2. Those two medications have revolutionized our understanding about diabetes.
Okay.
The reason is it's not only treating the diabetes, it's treating the whole body. So number one, they lower the blood sugar. Number two, do not cause any low blood sugar reaction, so it's very safe. Number three, both are associated with weight reduction. So keep in mind that 85% of our patients are either overweight or obese. So having 3 to 5% weight loss is an added bonus. Four, both lower the risk of heart attack and stroke anywhere between 20 to 5%. And one of them, called the SGLT2, would lower your risk of kidney problem by about 20 to 25%.
It's amazing.
And also lower your risk of hospitalization or dying from congestive heart failure, which is extremely prevalent in diabetic women who tend to be overweight or obese, by about 25%.
So what are some examples of these medications?
So within the SGLT2 class, the two that have or a lot of data to support that are two medications, one called Jardiance, one called Farxiga. Those are oral medication. They are pills. You take it once a day, and they work as early as the first 24 hours.
Wow.
The other medication are injectable. That's the class called the GLP-1. And there are multiple of them. The most recent one that was approved on Friday the 13th, is called Mounjaro, will be available in the second week of June, associated with a very powerful reduction of the blood sugar and significant weight reduction. And there's also another medicine called Ozempic and another medicine called Victoza. The Ozempic and Trulicity are once a week. The Victoza is an injection once a day. All of those medications, with the exception of the Mounjaro, have been shown lowering the risk for heart attack and stroke. All of the medication combined, they lower the weight, lower the blood sugar, with zero risk of low blood sugar reaction. So the good news is, in the last 5 years, we have some fantastic medication.
Yes.
But I always tell the patient, medicine by itself does not work in vacuum. You have to combine the four-legged approach. The meal plan, exercise or activity, behavior change and monitoring, and medication.
We should probably also mention to our audience that these medications for type 2 or adult onset diabetes.
Correct, not for type 1.
Type 1 is a completely different category. So it's
Thank you
important
for
to know
clarifying that.
Yeah, I just want that to be out there. So I think we're running out of time, unfortunately,
I know, and I
which
want
is
to
too
talk like
bad.
another hour.
I know we could continue to
Gotta
go for
come
some
back.
time. But is there a story that you want to share in the last few minutes, and maybe a message to our audience that you'd like to leave them with?
So I have that gentleman who joined us when we started our weight loss clinic. He was probably like the second or the third patient who come to the clinic. And when he came in, he thought that we are a bunch of amateurs because we have boxes that we have not unpacked. Literally, it was actually the very first week. And it was really amazing. He was probably 120 to 130 pounds overweight.
Oh,
So
I thought you were going to tell me that was his blood sugar. I was
No. So when he walked in the first time, I usually ask everybody, what is your goal weight? He said, I would like to lose 100 pounds. I said, okay, why don't we just start with something that is probably more reasonable? So let's start with 10% of your weight, and then we'll get to that. I said, no, anything less than 100 is unacceptable.
Oh.
So I kind of laughed.
Taking you to task there, Dr. Yacoub.
So we started working with him, and he actually was very, very highly motivated. We started, his A1C was about 9.5%, 10%. He was taking close to 100 units of insulin, 2 pills for diabetes, 3 pills for blood pressure. He had obstructive sleep apnea. We were using a CPAP. He was taking something for his reflux disease and a couple of medication for arthritis because he has chronic back pain because of his extra weight.
Sure.
Flash to the next scene. Not only he was going to the gym, he was actually counseling people at the gym, to the point that people thought that he was a personal trainer. And the owner of the gym, he went to him and said, you cannot do that. This is a big liability for you to counsel people. This is our job. So why don't you just do your thing?
Lay off, buddy.
So anyway, it took him about close to a year and a half, and he ended up losing the 100 pounds.
Really?
He came off the insulin on month number 3. His A1C dropped from 9+ to about 6%.
Oh my gosh.
At the end of the year and a half, he was off his 3 blood pressure medication.
Oh, wow.
He was only taking 1 medicine combined for the weight loss and the diabetes. That medicine worked for both. So he came off all of the insulin that he was taking. He was no longer using the CPAP machine because his obstructive sleep
Right.
apnea is gone.
Of course.
His back pain was gone. The only complaint that he had every time somebody would see him, they think that he was very sick because he lost a lot of weight.
Yeah.
And he kept telling them, I'm healthy. Thank you
Yeah.
for your concern.
Yeah.
But
Yeah.
it was like one of the most inspiring stories
That's
that I
wonderful.
ever
That's
came
great.
across.
How old was this gentleman?
He was in his late 40s, early 50s.
Oh,
That's
so
great.
it's like
Great
perfect.
story.
And
Great
during
story.
that year, he got promoted twice at work because he
Really?
has this incredible energy.
Of course.
And every time he come, he will actually teach me a few tips about exercise and different apps. He was very, very tech savvy.
Yes.
So he had his phone and he has his tablets and he has his computer.
Oh,
And
my
every
God.
time he come, he will tell me and teach me something new
That's a great
about the
story.
technology out there.
That's great. Is there a last message you'd like to leave the audience?
So, at the end of the day, it is the lifestyle. It is recommended for everybody, whether you're pre-diabetic or diabetic, or even if you do not have either, but you happen to be overweight or obese. So the three-legged approach is some kind of a reasonable meal plan, regular physical activity, and the behavior change, or the tracking part is prepare your food and keep track of what you're doing. I think those
That's
are the
great.
three most important message, or three pearls that we can probably get from today's talk.
Excellent. And get screened. Get screened.
Yes, and don't forget to see your primary care doctor once a year.
Well, thank you so much.
Thank
Dr.
you very
Yacoub,
much for having
This
me.
was really wonderful. A great conversation. I'm sure that everyone who watched this and will watch it will learn a lot. And I want to thank, of course, our sponsor, Bay Coast Bank, which is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Thank you, everyone. Thank you for watching The 27th Degree with Chris and Nancy from 27 Degrees Consulting. Once again, thank you, Dr. Yacoub.
Thank you very
Thank
much
you.
for having me.